Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Neville Riley. Welcome, YouTube. Peace. So we pick up at page 104. Right in the middle, in the center, pleural fluid. Peace. All right, here we go. It's a new day. Pleural fluid. The accumulation of any fluid within the pleural space will separate lung parenchyma from the chest wall. Because the fluid layer does not transmit vibrations well, there will be distant or absent breath sounds. There will be a flat percussion note. Pneumothorax. Pneumothorax is defined as the presence of free air within the thoracic cavity, and it is usually found in the pleural space. This will produce a hyperresonant percussion note with absent or distant breath sounds. Any shift in the mediastinum or trachea will be away from the side of the increased resonance. With positive pressure ventilation, a tension pneumothorax may occur. A tension pneumothorax is defined as free air in the thoracic cavity with pressure in excess of atmospheric pressure. Tension pneumothorax with positive pressure ventilation is immediately life-threatening. Because of the excess pressure, the lung tissue collapses, and more important, the great vessels in the mediastinum become compressed and occluded, resulting in circulatory collapse. Common physical findings include change in vital signs, tympani and hyperresonance, absent breath sounds, and subcutaneous emphysema, and shift of the trachea away from the affected side. The infant chest. We're down at the bottom of page 104. Clinical application of respiratory care. We are in Chapter 5, Clinical Evaluation of the Pulmonary System. Thank you so much for the likes and subscribes. We are pushing towards 500 subs reading books here on YouTube. Thank you so much for being here with us. The infant chest. Size and lack of cooperation make the physical examination of the infant chest difficult. Observation becomes the most useful technique of physical examination. The frequency of breathing in the newborn may vary from 30 to 60 per minute in the first few days of life. Premature infants often manifest Cheyenne-Stokes breathing, periods of apnea of 10 to 15 seconds between rapid ventilation. This Cheyenne-Stokes ventilatory pattern must be recognized as an expected physiologic phenomenon in premature infants. However, it must be remembered that apnea lasting longer than approximately 15 seconds cannot be considered physiologic and may be associated with bradycardia. The infant has a large protuberant abdomen and very high diaphragm. This makes the ventilatory efforts of a distressed baby extremely obvious. Since the infant's chest wall is very compliant, it is far easier to see retractions of intercostal and accessory muscles and the production of greater subatmospheric pressures in the pleural space. Flaring of the ala nasi is an extremely common sign of respiratory distress in the infant, and the expiratory grunt is a typical sign of severe respiratory stress. Assessment of the portable chest x-ray. We're in the middle of page 105. Thank you so much for reading with us. Hi, it's Heart Love. Numerous texts are available to describe the radiologic interpretation of the thorax. These tests are these texts are concerned with the finite points of diagnosis and are complete in description. The following material is presented to provide the respiratory care practitioner with some general helpful points of portable chest film interpretation in the critically ill patient. The respiratory care clinician is usually forced to use portable chest x rays, which are rarely of optimal quality and usually available only in the anterior posterior AP view. These x rays are used primarily to establish the existence of such entities as atelactis, a- atelactasis, pneumonia, pneumothorax, and mediastinal shifts. Principles of X-rays. When a photographic film is exposed to X-rays, it turns black. Thus, in a chest X-ray, the black portions represent areas where the X-rays went through the thorax essentially unimpeded. White areas represent tissue which has allowed very few X-rays to penetrate. As illustrated in Figure 5.3, the source of X-ray emits a fan-shaped wave. The greater the distance between the X-ray source and the photographic plate, the more spread out the X-rays. The further an object is away from the photographic plate, the larger the object will appear on the film. The routine chest x-ray is taken with the patient facing and touching the photographic plate. The front of the chest is directly adjacent to the photographic film, and the x-rays penetrate the chest from the posterior to the anterior PA view. This gives the sharpest and smallest cardiac shadow, since the heart lies close to the anterior wall of the chest. And here is figure 5.3. You'll see the X-ray source in A, the film image, and the photographic plate. And then in B, you'll see the X-ray source, the film image with the lines showing it distant. So it's a schematic representation. Thank you for reading with us. Clinical Application of Respiratory Care by Barry A. Shapiro and Ronald A. Harrison and Carole A. Trout. There you go. Second edition, 1979. All right. It says 5.3. Schematic representation of image size with X-ray exposure. A shows the greater distance between the X-ray source and the film. The larger will be the image because of fanning of the X-rays. The closer the object to the film, as in B, the smaller will be the X-ray image. Thank you so much, Black Boy. Hi, it's Hard Love. Thank you so much for being here and reading with us. This is to prepare people in the next level in the medical field, all that aspire to be doctors and nurses This is information that helps them with the MCAT. So thank you for reading with us here on our channel where we read books and learn from masters. Hi, it's Heart Love. Most portable chest x-rays are taken with the patient's posterior chest lying on the photographic plate. Therefore, this anterior-posterior AP exposure will give a larger cardiac shadow. It is important to remember this fact in the interpretation of portable chest films. Lateral views are seldom obtainable in portable films. Yes, and we're giving it to you for free. This is thousands of dollars of information. And, you know, that's what we do on this channel is we want to give the people the power back to heal themselves and to help heal others, especially parents like myself and others. This is vital information to helping us with our children and ourselves, self-mastery. So thank you so much. Live from the light here in LA. Thank you for the likes and subs. We're pushing to 500 subs reading books on YouTube. So, hi, it's Heart Love. Assessing the chest film. The thorax is an ideal region for radiologic examination since the aerated lung parenchyma offers little resistance to the passage of X-rays. And here's 5-4 before I turn the page and I'll read the caption so you can catch it. Thank you so much. These are chest X-rays and you'll see the tissue as well as the bone. Okay, there's 4 slides up there. And it says assessing the chest film. 5-4 comparison of chest x-rays A and B are standard PA films. A is inspiration and B is expiration. C and D are portable AP films. C is inspiration and D is expiration, in which the distance from X-ray source to film is significantly less than the standard films. Note that the chest image is larger in A than C because the distance from the source to the film. A has a smaller cardiac shadow in relation to the chest size because the heart is closer to the film in A than in C. Portable films are more likely to be of less than full inspiration. Comparing the expiratory films B and D with full inspiration, it becomes obvious that the interpretation is much more difficult when the lungs are poorly inflated. So you'll see again on B and D, you'll see it further away, smaller. Okay, and A and B or C are larger. We're reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Medical information for those taking the MCAT. Thank you so much for the likes and subs. We are pushing towards 500 reading books. Thank you so much. We are in Chapter 5, Clinical Evaluation of the Pulmonary System. Top of page 108. On the other hand, the soft tissues of the thorax, mediastinum, heart, great vessels, and diaphragm do not permit X-rays to pass through as readily. They appear as white areas on the X-ray film. The bony structures, ribs, vertebrae, and sternum are even less capable of allowing X-rays to penetrate, and therefore their shadows are the whitest of all. The normal appearance of the heart and lungs must be clearly understood before attempts are made to determine the existence of abnormalities or disease processes. Normal X-ray findings vary considerably with age, sex, and habitus. Different degrees of inspiration affect the appearance of the chest film. Figure 5.4. It is necessary to approach the interpreting of chest films so that one will be sure not to miss significant findings. Our recommendation is that the X ray be approached in the following manner: 1. Examination of bony structures and the diaphragm. 2. Examination of the heart, shadow, and 3. Examination of the tracheobronchial tree and lung parenchyma. Bony structures and the diaphragm. The ribs, clavicles, scapula, and a portion of the humeri are clearly outlined on most chest films. The outline of the vertebral column should be visible through the heart shadow unless the film has been underexposed. The two hemidiaphragms are rounded, smooth, and sharply defined. The right hemidiaphragm is normally situated slightly higher than the left because of the liver. The costophrenic angles are the junction of the rib cage and the diaphragm. These angles should be clearly delineated. The heart. The heart. The cardiac shadow should be sharply defined. Figure 5.4 shows the normal configuration, size, and location of the heart in the erect adult. Gross deviations from the normal are easily seen and assessed by the casual observer, but subtle aberrations must be left to the radiologist, cardiologist, and chest physician. Assessment of the tracheobronchial tree and lung parenchyma, down at the bottom of page 108. The trachea is a vertical, translucent shadow situated in the midline overlying the cervical and upper thoracic vertebrae. The hylae, or lung roots, are poorly defined areas of increased density in the mid portion of the central lung field. The hilus is composed primarily of pulmonary blood vessels, bronchi, and lymph nodes. At the level of the fourth thoracic vertebrae, the trachea divides into the right and left main stem bronchi. Normal lung appears black with fine white strings fanning out from the hylae. These are shadows of blood vessels and are referred to as vascular markings. These should be present throughout the lung, but should not be anything but very thin and wispy. Increased vascular markings or fuzzy vascular markings are abnormal. Atelectasis will appear on the chest film of as a density. A mediastinal shift to the side of the density may be present. Even segmental or subsegmental areas of collapse can usually be seen on a chest film. The location of the atelectasis is extremely important for appropriate postural drainage and re-expansion. A helpful technique for locating electric lung on the portable chest film is the use of the silhouette sign. The silhouette sign takes advantage of the fact that a density located next to or in front of the heart will obscure the border of the heart. Lung tissue that is collapsed and is located behind the heart will not obscure the heart border. If the heart border is obscured by the density, the collapsed lung must be adjacent to or in front of the heart. If the heart silhouette is intact, the atelectic area of lung must lie behind the heart. This means that collapse of the posterior basilar segment, the lateral basilar segment, and the superior segment of the lower lobe, and the posterior segment of the upper lobe will not obscure the heart silhouette. On the other hand, collapse of the middle lobe, the linguala, and the anterior basilar segment of the lower lobe will obscure the heart border. Miliary atelectasis is defined as physiologically significant atelectasis that is not detectable on the chest X-ray because it is diffusely distributed throughout the lung. Inflammation of lung causes fluid and blood cells to collect in the area. This shows up as a density on X ray and is termed infiltrate. Infiltrate or consolidation of lung will usually show up as density, but may be extremely difficult to see. The air bronchiogram can aid in assessing this lung condition. This radiologic sign takes advantage of the fact that the comparison of air-filled bronchi surrounded by consolidated lung tissue will be visible, whereas bronchi surrounded by normally aerated parenchyma will not be visible because of the lack of difference in density between the air in the bronchus and the air in the surrounding tissue. The existence of clear outlines of bronchi or bronchioles must mean that there is consolidated lung tissue around them. The application of bedside pulmonary function studies. We are on page 109 at the bottom. Thank you so much. Much love. Yes, live from LA, reading doctor medical books, helping the youth in the next generation for their MCAT. Yeah, and this is super high level. So we understand that most don't understand and can't, you know, really fathom reading some of this material. But that's why I'm here to do it, right? Love to the family and friends that we all have in the medical field, right? And all the healers, all the nurses. We just honor you so much. Thank you so much for reading with us. All those aspiring in the medical field, this is the channel where we're reading the MCAT material. At the top of page 110, distress, i.e., many observers do not delineate dyspnea from respiratory distress. When a patient is in respiratory distress, he is experiencing a phenomenon which can be observed and measured. Dyspnea is the subjective perception of difficult breathing and cannot be observed or measured. There have been numerous theories to explain the perception of dyspnea. A popular theory is that the perception of respiratory distress is processed initially in the subcortical portion of the central nervous system, CNS, and then perceived by higher cortical levels and interpreted. Other experts believe the neurons in the lung and tracheobronchial tree affect the subjective perception of respiratory distress. Some believe that the sensation is mediated via the vagus nerve. Ding! Peace be, highest heart love. Yes, we're reading the medical material that we manifested together. Thank you so much for being here. My mods are in the building. Thank you for helping to regulate the Mbangi as well. Peace. Contributes to the perception of dyspnea. The complaint of dyspnea must always receive careful attention. It is a most sensitive and reliable indicator that the work of breathing has acutely changed. To further emphasize the difference between dyspnea and respiratory distress, let us take the example of the chronic obstructive pulmonary disease patient whose baseline state is one of obvious shortness of breath. He has existed this way for a long period of time and will deny dyspnea in spite of shortness of breath and obvious objective signs of difficult breathing. The patient's subjective perception of his work of breathing is unchanged, and therefore he is subjectively unstressed. At the opposite extreme, a patient may be experiencing a paralyzing disease and complain of difficult breathing far in advance of objective signs. Pulmonary function studies are a means of objectively documenting and quantifying the mechanics of breathing. They do not necessarily have any correlation with the subjective complaint of dyspnea. Visual estimation of the tidal volume is notoriously inaccurate. Most observers are sensitive to increased ventilatory work and distress rather than the quantification of tidal volume. Clinical experience teaches that measurement of minute ventilation and tidal volume are often beneficial in exposing ventilatory pattern abnormalities not obvious to most observers. In addition, the gas exchange is documented so there can be serial comparisons throughout the clinical course. A meter for measuring tidal volume and minute volume must add little or no resistance to breathing and be accurate over expected range of flows. The spirometer, the ventilometer, is the most commonly used bedside method of measuring tidal volume and minute volume. There are numerous types of spirometers that are portable, simple to use, and accessible. Many are hand sized, and most have one way measuring system combined with a two-way flow system. In other words, the patient can breathe in and out through the apparatus, but only the exhaled air will be measured. The spirometer can be attached to a standard anesthesia mask and applied firmly but comfortably. The procedure must be explained to the conscious patient. If the patient is breathing through the endotracheal tube or tracheostomy, the spirometer can be connected through a universal 15 millimeter adapter. For accurate measurements, the cuff of the endotracheal or tracheostomy tube must be inflated. The simple spirometer must be used to make three bedside measurements of value, tidal volume, minute volume, and forced vital capacity. And that's where we'll pause this reading right here. Thank you so much for the likes and subs. When we pick up, we will pick up at the middle of page 111. We have done it. This is beautiful. Highest heart love. Thank you for reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. The highest heart love. Thank you so much for being here. We're shaking it up in the world, reading books. Love in the life. I want you to have a wonderful, wonderful Friday. thank you for all of your reading and gifts to the world. I'm using a wonderful new mic, a gift for my 46th solar return, which is coming up August 25th. So thank you so much for all the support, for the love. Love to Coco Elo Shun. Thank you for this blessing. Highest heart love to all my mods, friends, and family. I will see you soon, and we'll be back with another reading. Thank you so much. Yes, you too, beautiful brother. Oh, amen. Highest heart love and ashe. Thank you so much. Much love and honor. Let's take a sip of love water. All our friends and family, all our beloveds. Show them that we love them. Highest heart love. Mm. I love you. I love you. I love you. Thank you so much. We're pushing towards 500 subs, reading books live on YouTube. Thank you so much for making all of this possible. I tell you, this is my dream come true, to read wonderful works that help the next generation, that show we are one big family. Yes, V, that's right. We sure are. Loving one another. We uplift one another on this channel, and we help educate and give gems of knowledge from the masters on this channel, in this corner of YouTube, where we read books and learn from masters. So I want you to have a wonderful rest. We are going to the light green cloud tonight for rest and restoration. Okay, I will see you there. We're going to have some great material and some poets and some beautiful dancing. We'll be swinging on the swings in the wind because that's what we do in the peaceful place, right? We uplift one another and we love one another. So, thank you so much for all of you. Highest heart love. I love you, Bubbles. I'll see you soon. We have some greatness coming. I love you. I love you. And you know it. I'll see you soon. Peace.